Before we get started in this episode, a quick announcement. As you know, I'm very passionate about acceptance and commitment therapy, and I also run a busy practice in Canberra. We're currently looking for psychologists who are registered in Australia to join our team, who are also passionate about learning about ACT. We provide supervision on a group and individual basis and training around ACT. So if this is you, if you're interested, please express your interest at strategicpsychology.com.au/careers. Look forward to hearing from you. And now back to this episode.
Okay, life can be crazy. You're feeling like you're sinking, just trying to find a meaning. It's time for better thinking. Yeah, better thinking. Time to tune in. Let's go.
Welcome back to Better Thinking. My name's Nesh Nikolic, and my guest today is Kirrilie Smout. She is a clinical psychologist who has worked with children and teens for more than 25 years. She is the author of 3 books about young people and also the director of Developing Minds, a child and adolescent psychology clinic in Adelaide, and Calm Kids Central, an online psychoeducation program for children with big feelings. Kirrilie really shines a light on not only working with children from a transdiagnostic way, but also the evidence base around how children can be best engaged and parents in providing best practice therapy for future improvements in mental health. Really a passionate conversation, particularly towards the end of this interview, and really lovely to hear from someone who has a wealth of experience and is advocating for best practices in Australia for children and adolescents. Big thank you, Kirrilie, for coming onto the show today. I appreciate you taking the opportunity to come on, and I think there's a bit of a shared interest in the transdiagnostic world, so it's always very lovely to speak with a colleague, around that, and obviously other areas too.
It's a pleasure. It's lovely to be here.
Tell me a little bit about maybe a little bit about yourself, and obviously what's brought you into psychology. Obviously, the transdiagnostic world. I know that we spoke about ACT before starting this recording as well, and maybe we can kind of start there and progress from there.
Sure. So I graduated from uni. I was thinking as you were talking, Nesh, I should have memorized that. I have behind me actually a certificate which says 20 years, which I got back in 2016. So wherever that leads us to around about 27 years, my maths isn't good, of working in clinical psych, and started working with both adults and young people, but fairly quickly decided that working with kids and teens was the way to go. So I have been working in that field specifically probably for the last sort of 22, 23 years. And that's been in a mixture of community settings, private practice settings, and some government settings, and also have in the last few years also been working in tertiary settings as well, where I get to do some teaching and training. So at the moment, most of my time is taken up by working in a private practice called Developing Minds. So we have about 23 child and adolescent psychologists here who see lots of wonderful families each week, over a couple of different sites, and that's working with kids aged from about 4 to 18, and they might come in with all kinds of challenges and struggles and goals, which span lots of different diagnostic categories. So I get to work with them and also supervise the psychologists in our practice. And then one day a week, I work at the University of South Australia, where I support, supervise and teach provisional psychologists in the master's program there. And then another big part of what I do is working on our online program, where we have a child mental health support program for 4 to 11-year-olds, so the primary age group, where we're trying to give resources to both practitioners and also to parents around helping children increase their emotional health literacy and learn how to manage various problems. So that program is not for parents specifically, it's actually for children, because we know there's quite a few online parenting support and caregiver programs, but the programs for children themselves are a bit thinner on the ground. So that's where that program fits. So I think that's a bit of a summary of the crazy juggling of work that we all do. And that's sort of what I spend my days doing.
Busy schedule, I see.
It's a busy schedule. It's mostly good. There aren't too many days that I'm looking to quit and become a florist, just occasionally.
Tell me a little bit about, if you don't mind, the university teaching part. I'm interested to find out about how are we doing our teaching at a university level. Is it still very DSM strong? Are we looking at it from different lenses? Is it broadening from there? What sort of modalities are we teaching? I know that obviously CBT is still at the forefront and should be. It's got great evidence base and the like.
Yes.
But I'd love to hear from someone who's in that space.
Sure. Well, I'm only there a half a day a week, so I can only comment on what I see, and only at the one university. But
Sure.
yes, CBT is probably the dominant framework that is taught. However, there's definitely exposure to lots of different modalities in terms of understanding what they are. In terms of the DSM heaviness, although DSM frameworks are definitely an important part of teaching, it's absolutely understood that they have limited usefulness. So there is, I think that new graduates today, can you just excuse me for a second? Sorry, Nesh, I should have put that on silent.
No, that's fine.
I definitely think that my opinion would be that most universities have a really heavy focus in clinical masters on understanding both the benefits and the limitations of a medical model or a DSM model. So it's certainly not a rigid, you need to diagnose every person that comes in and use a kind of single diagnostic approach.
Yeah, I've heard recently, and obviously we have some provisional psychs on our team as well, and they've certainly come out with that great understanding where there is much more of a focus on the process and understanding the client's story and the factors that are contributing to why someone's feeling that way, rather than trying to come up with a specific diagnosis. And it's so lovely because, certainly not taking away anything from my training, or maybe I was misreading things when I went through, but it seemed quite heavy in trying to understand someone's presentation and put a label to it, or at least maybe that's how you understand how to put labels. And there were always fringe cases that we looked at, but maybe younger eyes, I couldn't see that. But it seems like the young ones coming through, really bright, really well developed in whether it be case formulation or treatment planning. I've been really impressed.
Yes. I think the kind of rigid focus on diagnostics and using single protocols is really been in the research world rather than in the clinical world. I think that clinicians have always, from the time they either stepped out of university or even within the tertiary system, understood that life is not that simple. And so I think, obviously I only can come from the universities that I've been involved with, but I think that they're generally pretty sensible and have been for a long time in understanding that transdiagnostic, transmodal, kind of individualized way of treating people, and particularly children, is really the way that we have to and what we do.
Well, it's always surprised me, and maybe I'm a bit sort of repetitive in this sort of space, but it's always surprised me how we know that if we had 10 clinicians speak to the one single client, they would all be able to describe the client's story and experience and what's occurred, but there could be quite significant variation in a diagnosis, whether it's adjustment disorder, whether it's a PTSD, whether it's some sort of social phobia. All sorts of strange things can come out of, the variation of that, because it's very difficult to package this together. And we know we do confirmation bias because we are human. So if we're looking for something, we can kind of see that. I mean, I've been in my own trap going, everyone's fitting the adjustment disorder because it's an all catch type of space, when in actual fact it's irrelevant. I've just got to put something down on a insurance form as to what it is, and in there is where we I think tend to struggle when we're being not forced but asked to, and it's hard to push against the system and say we don't do that at our practice. We don't give these diagnoses because it can have serious ramifications for whether someone gets support or not.
Yes. And there's some particular challenges with children in diagnostic categories. So, for example, being diagnosed with autism is often an avenue to being provided with NDIS funding for support. Being diagnosed with ADHD may open up some additional avenues of support at school. Not always, of course. But sometimes for children having a dyslexia diagnosis, for example, may open up accommodations. So there is, as there have always been, some advantages to diagnostic categories, as well as some of the disadvantages that we naturally as clinicians sometimes want to push back against. So it's balancing using the framework when it's helpful, but being aware of the risks.
How do you balance those things in terms of seeing that there's a great need, but sometimes, there might be some question marks whether we see a presentation that meets the full criteria? How do you do it?
Well, I think it's been using our collaborative, open, conversational skills that we want to be using about therapy with the topic of a diagnosis when we're talking with families, and talking just openly about the fact that these are how disorders are diagnosed, with all of their strengths and failings with that process. And here are the risks and benefits of diagnosis, and asking families to tell us what suits them and what would be helpful for them, rather than coming in as an expert with kind of a hard line of either you need a diagnosis or you don't need one.
Mm-hmm. And how have you found that's changed over the years? Has that been something that has been the way that you've worked, and obviously your team as well, over many years, or has it kind of evolved and changed?
I think there's been a societal shift towards being aware of diagnoses, like particularly, for example, diagnoses like autism or ADHD, but even, anxiety disorders and depressive disorders. We definitely have more families now who have greater awareness, understanding of what those diagnoses mean. And we will have families seeking those out from us more frequently than we did, say, 15 years ago. And partly, again, that's to do with, funding and doors that open with them, but partly it's, I think, just the general mental health literacy of our society, which of course brings lots of wonderful benefits in de-shaming and, not placing kind of inappropriate blame. But it also, unfortunately, means that we have this diagnosis creep that happens with all diagnoses. And so we have increasing numbers of people falling into a category that maybe doesn't fit them. Or at least being interested in it in diagnosis that maybe doesn't fit them.
It's so interesting, talking with yourself and other colleagues. I know I always get really nervous, and maybe that's just a sign of the times, but nervous about, what constitutes a diagnosis and how it's looked at, particularly in some of these more challenging spaces like, ADHD, where obviously there are lots of things that can be contributors to why a child is behaving in a particular way or not engaging in times when we would like them to engage, particularly, around, things that can often seem to be very reasonable and normal, particularly with certain character traits, like we know, quite strongly that there are great variation in people, and there's great strength in being able to switch topics and in actual fact be, whether it's spontaneous or be empowered by juggling multiple things simultaneously, particularly in this changing world. And then also, great problems that can come along with that if you're asked to sustain attention on a boring task. That's hard for, the best of us.
Yes.
But it's always challenging. I'm always kind of worried, like, who's listening? Am I going to get picked up on this? Maybe that's just my own fears, but I know that I feel just personally, naturally sensitive about how do I talk about this, particularly when it's going to go public.
Yes.
Have you felt that as well sometimes?
Yeah, I think so. I mean, I've been really grateful for the advent over the last 10 years or so of understandings of neurodiversity and that social movement and framework that has helped us understand differences and the, I guess, context-specific benefits or disadvantages of those differences, rather than using a purely biological or medical model which sees symptoms as, diseases and problems. So I think we have more language to talk about this now than we used to. I think maybe I feel less nervous perhaps now that we have an understanding, and I think that society is also gradually taking on that understanding as well, that we don't just have to be stuck in a biological medical model, but that we can draw upon that as well as thinking about social models of disability and so on. But it's certainly a tough area at times to work in. As I said, I think the only solutions that I've personally found to be helpful are those around being authentic and open with families about my views and listening to their views, and to invite them to let me know how they would like to manage the issue of diagnosis.
Can I ask you potentially a harder question, in terms of what's your standing on diagnoses? Are they is it something that you see as a medical model, that these things exist, or is it best that we hold that as a professional means of communicating with one another or describing something for someone, but it's better explained by, a functional analysis of the context and what someone presents with, that describes what we would more than likely usually feel if we were in the same position? How do you sort of see that space?
Could you rephrase that question for me, Nesh? I'm thinking
let me try and be a bit more direct. Do diagnoses exist?
Well, I certainly think patterns of behaviours and feelings exist. And so how we describe those then becomes a decision that we have to make as both professionals and families. But there's no doubt that there are people with a collection of behaviours and symptoms and experiences that are very different from somebody else's. So in that respect, yes, absolutely, there is some permanency or some longevity to those experiences that can kind of be grouped together. So, if you take ADHD, for example, there's no doubt in my mind that some of the families that I deal with are supporting children who are at the 98th percentile in terms of their tendency to be active or to struggle with concentration, for instance. So yes, in the world, that is a very real experience. It absolutely exists.
Mm-hmm. They're the tail end experiences where
yes.
we can see, I suppose the great challenge is how often are we seeing the tail end, and how is that understood? Because for me, it's always like, that that kind of understanding of, if we look at the extremes, it's very easy to see ASD when it's in the very severe range, because anybody can observe that. Someone that is untrained can go out and say, I can see the severity in this child and that they're going to need ongoing support and they won't be able to achieve independent living. And then there is obviously what we used to call, Asperger's, where there's lots of functional capacity. And I know that we kind of try and do, mild and moderate and so on, but it becomes harder and harder. It blurs the lines the further we go into that middle space. And, that always poses a question. Sometimes it's easy to go out and say, wow, someone's been, diagnosed with schizophrenia, for example, and it seems to be long standing and it's, they're quite often in an active episode. And it seems like there is something a bit more organic, and maybe there is a medical model start to show up in that space. But it's a lot harder to kind of see that, where someone may have had a manic episode with some depressive types of moments, and now we kind of label them with bipolar, when I'm not sure what the dysfunction is, when that might for one person be an episode, so to speak, of euphoria, that they made some poor judgments at the time. So it's hard to grapple with the two spaces, because sometimes it's so obvious, but then like the 98th percentile, and then there's kind of a question mark about how do we do the others.
Yeah, I'm not a diagnostician, Nesh, so I tend to leave some of those questions for people who specialise in those areas. But I agree, definitely the grey areas, this is slightly sub-threshold, are harder to manage.
You're probably smarter and wiser than me, because I kind of want to get into the weeds of that and try and figure that out. And there probably isn't a solution. I think good clinical practice is the solution, that we are well versed and educated in both understanding it from a DSM perspective, because we're working in the modern world, and similarly trying to understand how do you do support and therapy and treatment, and what does the evidence base say around how to help people who are presenting in a particular way.
Yes, I think that's certainly our focus here, and I think one that most clinicians sort of have to grapple with is regardless of diagnosis, we need to go ahead and think about how do we actually support this child and young person to live more functionally.
Can you talk me a little bit through? I'm not a child sort of psychologist or even adolescent psychologist. Can you talk me through about how your experience is with working with parents, and what are the challenges that parents have when they're trying to support their children? I know it's fairly broad, but what are the types of presentations that mums and dads come with that we can support them with while obviously working with their children too?
Well, the most commonly diagnosed, again we're talking about a diagnosis, the most commonly diagnosed mental health challenge for children in Australia is ADHD. And then when you look at presentations at mental health clinics, then difficulties related to challenging behaviour, so that might be children who find it really difficult to cope with instructions, who find it difficult to manage their frustration, who get really overwhelmed and act in aggressive ways. Those groups of behaviours, challenging behaviours, are the most common reason for presentation to mental health clinics in Australia. But that's shortly or closely followed by symptoms related to anxiety. So anxiety around being separated from mums or dads or other caregivers, anxiety about social situations, school and learning situations, and so on. Of course, they usually are overlapping. So most children who struggle with challenging behaviours will also have experiences of anxiety and overwhelm, and many children who are anxious will act in challenging ways. Of course, then you have many children who struggle with trauma-related symptoms who've been in experiences in their family which have been traumatic for them. And you also have lots of young people who have difficulties with peer experiences and relationship experiences. They're, I guess, the most common challenges that families that we see come along with. And I think that's echoed in lots of other child psychology clinics across Australia.
Has ADHD been the most diagnosed for some period of time, or has that changed with recent awareness that has made people more and more cognizant of mental health challenges?
Yeah, sure. Well, we'd have to differentiate between the official diagnoses and the presentation, I suppose, in a way,
Sure.
Nesh. So the official diagnosis rate, and I'm hoping that I'm correct on this, don't quote me on this, but I believe it's actually stabilized in recent times. There's more adults being diagnosed with ADHD, but the rate for childhood diagnosis hasn't, although it increased some time ago, had been steadily increased for many years, has sort of leveled off. And I wonder if that's actually partly because in terms of services, it's so difficult to actually get into a psychiatrist or a pediatrician who's willing or able to diagnose ADHD. But yes, in terms of whether the presentation itself is increasing in terms of the families who are needing support, I suspect that there are more families that are coming to see child psychologists or wanting to come and see child psychologists than there ever were. So sheer numbers would suggest that there's more of those.
That's such a profound point for me. I've never thought about how rates might be shown in relation to the number of clinicians that might be available, and that you would hit a ceiling because you just cannot go out and diagnose anymore because we've got a certain amount of clinicians who are all maxed out, seeing their total caseload, and they can't see anymore. And so there's going to be a ceiling to everything, right? Even though there might be a lot of people who are waiting, but you can only do that, based on the number of clinicians that the system has available.
It can be, yeah. I mean, there is some prevalence data that's collected using community-based surveys where researchers will diagnose or use diagnostic systems themselves. So they're not actually asking people, have you received a diagnosis? They're actually taking a sample of the population and diagnosing. But of course, that requires pretty expensive research, so that's not always done. But yeah, I think I know that certainly there are lots of people in Australia who just simply can't get a diagnosis or an assessment done at the moment because of wait times.
I also wonder how often human nature gets caught up as clinicians. How do we behave ourselves where when someone's asking for something, how hard do clinicians find it to not say yes to maintain their clinical opinion? You know how, like in scenarios where if a client comes in, they say, I already have a report and it says this about me or this about my child. It's so much harder for a clinician to go out and say, I'm going to hold my ground and say, I don't agree with that. I wonder even there, and not suggesting that we're not doing a wonderful job and that everyone's thinking about the same a way to treat people and the like. But I wonder how much humanity comes in and we struggle with it ourselves, because, even when someone contacts me and says, Nesh, can you make an appointment? I'm like, it's going to be hard, but I want to say yes, right? I want to. So even at that level of making an appointment, let alone, is there another way I can, or is there another way you can help me?
Yes.
That would be fascinating to look at as well.
You may need to talk with some of the clinicians who are involved in those diagnostic services to see how they manage that, because I imagine that there is some pressure, but possibly in both directions, however. So it'd be interesting to see what they do about that.
Mm-hmm. In terms of the services that you provide, when an assessment is made and recommendations are provided, are the recommendations that you provide something that your clinicians then continue to work with that young person? Are there services that you refer out to? Is it a combination of both? How do you?
Well, we actually
manage
refer out for assessment. So we're a treatment only service.
Okay.
So our focus is on therapeutic support for challenging or difficult experiences, behaviours, and presentations, rather than doing that diagnosis. So we will then be doing a therapeutic assessment with families to think about what are the most difficult experiences they're having, prioritising those, setting goals, and then using various treatment approaches to try and see if we can get increase in function and reduction of symptoms.
Yeah, fantastic. This is a nice little segue, if you don't mind, for me to ask about your online program. I know that the more mediums we've got, the better, particularly with young people being able to, do things in their own time. The adoption of all of us moving towards what we're doing even right now, doing a podcast versus almost like a Zoom, I suppose, a telehealth type of scenario, or for kids to be able to watch videos. Can you talk me through about your program, what it offers, and how it was developed and designed, and why?
Sure. It was probably around about 8 years ago now that we started seeing the increase in referrals we really couldn't keep up with, and nor could we refer out to other people who were, other services that we tried to refer to were also becoming at capacity. So that's where we started looking at whether there was a low intensity model that we could use for people on waiting lists, or in between sessions, or who weren't able to or willing to come into clinic. It was also partly because of the workforce shortages. Of course, it meant that our rural and remote families were really finding it difficult to get access to services. So that was the initial prompt, I suppose. And since that time, we've been able to develop a whole range of different modules for children. So the program consists itself of around about 30 little modules for kids aged 4 to 11, which include things like, using calm sentences when we're frustrated, developing a busy brain when we're angry, having friendly conversations and what that might look like, understanding our danger checkers and what they do to us, being able to relax our body, and so on and so on. So each module has a 2-minute little animated video, an interactive game where they have to drag and drop and spin wheels and things just to cement learning, a discussion guide that a parent or caregiver will use to ask them questions about what they've learnt, an activity sheet that they would do on paper, and then a monitoring sheet, which is a homework embedded sort of idea about kind of ticking off practice and so on. As well as that, we also include a question centre where parents and caregivers who are supporting their child to use the program can jump on and ask one of our clin psychs a question, and we answer them within 48 hours. And then there's also a separate library for parents where they've got some information on a whole range of modules about how they might support children with big feelings and difficult behaviours and anxiety and so on. And so we've had about 5,000 families over the last 8 years use the program. It's funded by a range of different funding bodies. So some people in Australia have access to it for free, depending on what region they live in, or whether they have various kinds of private health insurers will fund it, like HCF, for example. And we do some outcome monitoring to see whether it has made a difference. And we're quite happy with seeing the changes that occur when people use the program. So that's, I guess, in a nutshell. I think what is interesting about the program is that it helps us think about what we're doing in sessions as well. So we've been able to develop modules that can be put together, I guess, transmodally, to think about how we do treatment planning. And I find this area really interesting, Nesh, because I think this is how clinicians work. They don't follow manualized protocols. And what they need is, I guess, lists of all the different treatment kernels that can be useful to be able to then do case formulation to kind of put these together. And so our online program kind of gives all of those kind of different modules that clinicians can then think about picking and choosing from. So while we've been developing this program, Calm Kids Central, it's called, by the way, for families, it's also been helpful in helping us think about, well, how do we treat and support families? And what are the different kinds of things that we might use depending on the symptomatology and the causation of those things? Is that, I've just kind of thrown a whole lot of words at you there, Nesh. Tell me, what can I
look,
how can I dig into that?
Look, I tell you what strikes me, and you know, it's just so beautiful as well, is to hear the topics and how that's delivered, like, you know, building a busy brain. You know, these are little things that, you know, it's going to be much more accessible for whether it be the kids, but also the parents, that they can use that moving forward. That you know, these are concepts that in so many ways, you know, have a metaphor or have a little catchphrase attached to it that obviously, as a psychologist, you know, you could do, you know, 10 sessions on well, you know, you could do unlimited sessions on each one and look at all the nuances, but it starts a conversation. It's really the building blocks of you know, being able to observe, you know, one of, you know, 30, you know, it's probably much more than that. They're just your modules, but I'm sure there's more than just those topics in each module. So it's beautiful because it gives a language set, and, you know, being, you know, bit of a language fan in, you know, looking at the ACT model and RFT and, you know, sort of how language represents things and so on. You just rattling off those modules just is so elegant and beautiful.
Thank you, Nesh. That's very kind of you. That's what it's like to be a child psychologist. I think it's interesting that child psychologists are forced very quickly to have to take a complex concept and think about what's the really the heart of this idea that I need to now explain to this 7-year-old in 5 words or less. What does it really mean? And how can I make this practical? Because you don't have the luxury of being able to have a 50-minute kind of meandering chat with a 7-year-old. You've got to be on task, fast, and get to the point. So you've got to be pragmatic in what you're doing, and you've got to have something that they take away with and do. And so, you know, one of the beautiful things about working with our team of child psychologists here is just seeing the creativity and the ways that people do that. And I've always said that I think that once you've worked with children for a few years, you can work with adults much faster and more effectively, because you've had to be able to do things in a way that's much more succinct and much more practical than you would do if you've had, you know, a bit of more time and space to explore ideas.
I've always wondered that, and obviously raising children myself, obviously the differences between adults and children is immense. But I've always thought about it in the way that, you know, with an adult, it's very, very challenging because you need to change your mind. You know, so you've got to get things out of the way before you go out and adopt another viewpoint or consider another viewpoint. There's, you know, you've got to get your confirmation bias out of the way and so on. With children, you know, in you know, some instances, there's an opportunity for a child to just make up their mind. You know, so it's almost like, you know, now we're going to play horsey, right? And then we become horses. You just decided I am a horse, right? As we're, you know, to say, look, you're a horse to an adult, they can play it out, but they don't buy in. There's still all these things that are in the
Yeah.
way. So, being succinct allows children to say, okay, that sounds reasonable and right, and I can just start living with that, or adopting that viewpoint. Which obviously, lots of parents would benefit from as well, because that language and those ideas, we often, especially being a busy parent, we often can't even think of those things. And I'm a clinician, so and I don't even go there myself, right? I'm not a clinician at home. I'm a dad, right, and a tired one of that as well.
Yeah, I think having parents exposed to these ideas, I mean, one of the things that we always want to do for younger children is to have parents and caregivers in the room. And also when we are having children watch modules and do activities online, we want parents observing, watching, because what that does is that then does give them the analogies, the language, the ways to describe ideas that is developmentally appropriate and more likely to be effective for children. So although a lot of the modules, although a lot of our program is designed for children, we know that we're sneakily getting in education and support for parents and caregivers as well. So that's where often we're doing some of the best work, is helping families know what to do themselves.
Well, it's very much a systems approach, isn't it? Where if both are involved, there's whether it's a shared terminology or a shared goal, or that parents can say, I can observe my child is doing X, so I can support in this way. It's obviously a much more laid and profoundly valuable program. Do you mind just quickly jumping into, you said that you have evaluated the program. What sort of things have you looked at? And obviously,
we use the pediatric symptom checklist and look at pre and post results after 4 months of using the program, and we have seen significant reductions in total distress scores. It's unpublished at this stage, and we've got to do some more rigorous research. There's been no control group. There's lots of work that we need to do in doing that, but initially we're seeing some encouraging results. But what I am most pleased about is that we also have around about 1,000 clinicians who've used the program and continue to use the program. And I find that really heartwarming, Nesh, because I know as a child psychologist, when I walk into a room, that some of the time you just need a resource. You've got a child that you've got to introduce some concepts related to, for example, challenging their thoughts, and you've just got to have some kind of entertaining, or at least slightly entertaining, visual kind of component activity that you can do. And so just being able to have that there is helpful. But do you mind if I go back to just a point that you made before about involving parents? Because I just think this is such a important topic for us as therapists, and figuring out how we do this, because the societal expectation is that you send your child along to see a psychologist, and they will try and support that child. You might kind of know what's going on, but essentially it's a child working with the psychologist. And we also know that this is the way Better Access has been designed, that under Better Access, the deal is that the child is in the room and you're supposed to be working with the child. Yeah. This is in stark contrast to most of the literature. Most of the literature says that if you have children, particularly those in primary age child, your best bet for best outcomes is to be doing work with the parent. And most of our RCTs in psychotherapy don't pit one type of treatment against another, except there has been quite a lot of work pitting parent treatments against child treatments. And what they find is that parent treatments for younger children usually get better outcomes than child treatments. So not only do we have that literature, we also have all the literature which has our parent work for children with oppositional and difficult behaviours showing good outcomes. So we have this whole mountain of research that says we need to work with parents. And unfortunately, child psychologists across Australia are struggling with this because not only do parents not really understand that, our Medicare system doesn't really understand that. And so I continue to be waving the flag, and I'm sorry to be a boring kind of, talking about this, but I just think we have to keep getting that out there. I'm doing lots of advocacy with various politicians at the moment. I know that the APS are working on this as well, and have been for quite some time. But we really need to continue to lobby and explain that not only are we hamstrung and not able to get good outcomes when we're working with children under better access, we're also potentially damaging many children's relationships with their parents, because what happens is you have to have a parent come in with a child, you ask mum or dad or caregiver, can you give me some information about what's going on? Mum or dad, of course, want to present or explain the difficult experiences that they're having with the child. And so time after time, every day, we would have across one of our clinics a parent saying some extremely harsh, critical, potentially massively relationship rupturing statements about that child while that child is listening. We also will have adults feeling the need and understandably needing to tell us about traumatic events in that family's life, including family violence, that the child is now sitting here with big ears listening to all about the family violence that's occurred. So it is just heartbreaking that as clinicians, we are not only doing poor work at times because we can't have the parent in the room on their own, but we're actually making things worse for a child under our national mental health system. So I just think it's something I'd really like us all to have uppermost in our mind. And this is particularly important when we're thinking about the fact that challenging behaviours, oppositional behaviours, most common presentation, as I said, into child mental health clinics across Australia, and potentially in terms of health dollars cost and long-term disturbances and problems, more expensive than any other mental health problem, because you might have an adult walk in with a significant, serious mental health problem, but that the years of life that they have left to go, 20 years left than the 5-year-olds that walk into our child psychology clinics who've been suspended from school, expelled from 3 schools, have serious difficulties. They are going to have 40 years of cost to our health system, and we can't treat them effectively because of the way Medicare is set up.
Kirrilie, thank you for your extreme passion on this topic, because it needs to be said. It's absolutely horrendous and absurd that we've got an evidence base which goes out and says parents need time with a clinician by themselves. I mean, that is, excuse my language, but bloody obvious. Yeah. And hence why, parents are desperate to communicate with their psychologists without the child knowing, and so on. We've all done it as parents ourselves, because we know that there are huge damaging potential problems, as you've noted as well, of doing, trying to say something in the room, or you're unable to because now you're speaking in code and the message isn't relayed across, and other sort of issues are formed. And as you said, I know the APS have been on this for some time, and we do need our government to go out and say, yes, we are going to not only give children their 10 consults a year, but maybe we give mum and dad 5 consults on top of that, so that they can speak openly and honestly, and that way a clinician can work with that child and the parents, and obviously combined when needed, to give them the best care, as you say, because they've got many years of life ahead, and we know that early intervention across the board for everything is the period, right? So that's where our money needs to go, ahead of a lot of things. And unfortunately, this isn't even a money thing. This is a policy thing.
Well, it doesn't actually have to cost more. Ideally, we would have more sessions, but what we need is the flexibility for clinicians to make the decision whether the parent or the child is there. Now, there were 2 extra sessions announced in the recent budget, or the May 2021 budget, and they were supposed to be coming in next year, but they've been held up, I understand it, by looking at issues to do with consent, because what they wanted to do was to introduce 2 parent caregiver sessions. So that wasn't just for children under 18, it was for all family members. And so because of that, they introduced tricky and thorny consent issues, which has stopped it happening. So if anybody's listening and they have the ability to, or are willing to go and talk to their local federal member of parliament, please just drop them an email to let them know that this is something that's really urgent and not necessarily more expensive.
And I think it's important to have, for clinicians to have a voice in here and speak to their relevant minister, but also for mums and dads listening,
correct,
or loved ones to go out and say this is important and it needs to be on the agenda, period.
Now, in the meantime, although we are very hamstrung, what we still have to do is to work on how we support families to be involved to the extent that we can. And that is the other slightly related but slightly separate issues that child psychologists face, is that parents are often not aware that what is most helpful for their child is for them to be learning how to respond to support their child. And a lot of the time, clinicians don't feel able to, or find that there's lots of barriers in the way in actually having those really collaborative conversations with parents where we're up front and say, I can't probably fix or even make a huge amount of difference to your child's challenges by just working with them. I need to work with you. What that means is that we're going to need to have, 6 sessions with you doing 5 to 10 minutes work a day with your child. That's my understanding of what the evidence suggests will be most helpful. How do you feel about that? You probably came in with a different understanding of how this would work. Tell me about how that fits with your emotional resources, time and ability at the moment. But to be a little bit bolder and more upfront in being able to talk with parents about that, because the reality is that if we sit in a room with a 7-year-old and teach them emotional regulation techniques on their own, chances of that making a significant difference for a highly dysregulated kid is probably pretty low.
And I think you're right in terms of, talking about being bold. I think we have a responsibility as clinicians to go out and say, I need to go out and raise what the evidence base says. And if the evidence base, with an adult is, we need you to be, consistent and attend more than, 3 appointments before you finish up. Because the evidence tells us the more sessions that you have, the more chance you're going to adopt some of these concepts or, be able to integrate them for a longer period of time, post 12, 24, 36 months. I need to just at least inform you that this is what would be, recommended and most appropriate. It's then up to a person to decide whether they can achieve that or not. But I think we've got to be, at least up front, I would want my doctor to say that to me as well and say, Nesh, you should go out and run for 30 minutes a day. And then I can reject that at least. But at least I can have an opportunity to adopt it,
Yes.
And then, it can still be done respectfully and thoughtfully and obviously professionally and clinically. But I think we've got an obligation to be bold, because I know that sometimes being so client-centered, we can get a bit too collaborative. Not collaborative is probably not the right word. We can maybe not state it as thoroughly or as directly. Even though our heart and our intent and our clinical knowledge says that's exactly where we want to go.
Yes. And we leave it till too late to bring that up often. And I think that then it becomes a more difficult conversation because it can be interpreted as a criticism and an attack of what has been happening. Whereas if we can lead with it up front to talk about what the treatments that tend to get the best outcomes tend to be like, with spacing, with out of session activity, with types of work, and then we can say this is what we would expect, and as you said, get client feedback on that, but do that from the beginning.
Absolutely. Beautiful and wonderful to hear, and I think have an opportunity to talk about this sort of stuff on a podcast that hopefully others can listen to. I just want to thank you immensely. I know time's of the essence, but I want to thank you immensely because these are the topics that I think we need to talk about so that we can also change psychology. Now whether it's through policy and talking with those Medicare and the like, our ministers, or even reflect on our own practice and say, how do I set up, sessions and expectations? How do I navigate the tricky world of diagnoses and the like? These are all fundamental questions, and I think psychology is moving rapidly because of these questions that are being asked, that we are wanting psychology to evolve, and we're also seeing what works and what doesn't, and needing to voice that and make that more of a reality, and for the world to see that as well, saying, oh, I know how to meet a child psychologist. It means I'm involved. As a matter of fact, the more I'm involved, the better. It's
Absolutely.
Just that the focus is going to be on my child, and I can do countless hours of therapy with my child, and if we actually drop the word therapy, support and nurturing and kindness and guidance and modeling is probably the big one, right? There's so much that I can do to be my child's parent.
Absolutely.
How can people find out more about you, your clinics, the work that you do, the online program, and the like?
Sure. So the online program is called Calm Kids Central. So you can just go to calmkidcentral.com. If you're a professional, then there'll be a link there to direct you to the professional site. Our clinics in South Australia are at developingminds.net.au. So you can find us at either place.
Now, I hope I don't stumble into something where I've read it somewhere else, but do you have a couple of books as well that you've read?
Yes, I do have a couple of books. I've got the When Life Sucks book. So I've got the When Life Sucks for Kids, which is for primary age kids, and the When Life Sucks for teens.
So we need to develop When Life Sucks for adults as well.
I'll leave that one to you, Nesh.
No, big thank you again, and in particular for sharing your passion. I love hearing psychologists who bold enough to kind of say this is what's on my mind, and this is what I believe in, because that it's refreshing for all of us, and I think it's refreshing for mums and dads as well to hear that we are on their side. And sometimes it's hard to do our work, and we're trying to do this together as a unit to support young people. So thank you for your incredible insights and experience.
It's a pleasure, Nesh. Thanks for having me.
If you enjoyed this podcast, please support it by going to iTunes and putting a review, subscribe, share it via social media, and tell others about it. Start a conversation. It's listeners like you that make this able and possible, and why we bring in these guests to go out and share their knowledge and resources. And just lastly, if you are a psychologist and you want to go out and be part of a bigger team, develop your experience and get into some exciting work, come to strategicpsychology.com.au/careers and reach out. I'd love to hear from you.